Hi, my name is Rachel Miller. I'm a PA in general surgery. Part of my role in caring for our surgical patients is helping them to navigate decisions regarding life-altering or potentially life-threatening diseases. These conversations at times can be challenging and yet very fruitful in helping to bring to light their hopes, values, and fears that they have in regards to care for their serious illness. My hope is that this video will help you as the patient or supportive friend or family or caregiver understand some of the terminology surrounding care options for people facing a serious illness such as sarcoma. This video is really meant to be a starting point for thinking through how to gather information and how to process different care options that are best in line with the patient's needs and wants. Advanced care planning is a process of communication between the patient, a close family member, friend, and medical staff for the purpose of identifying a healthcare power of attorney and clarifying treatment preferences at the end of life. It is often a series of conversations that take place between a patient and their loved ones, alongside the patient's healthcare provider. Advanced care planning is really good to think about at any time, but is especially important if you are diagnosed with a serious illness like sarcoma. It's a good idea to revisit or to think about planning for a situation in which you couldn't speak for yourself, and that's really what advanced care planning is all about. Many people are faced with a serious illness, worry about burdening a family or loved ones by having them make medical decisions on their behalf if they're in a situation where they couldn't speak for themselves. This is where advanced care planning can really help decrease that burden by both making and communicating a clear plan by answering two big picture questions. Who would you want to speak for yourself if you were unable? What would or wouldn't you want done if you couldn't speak for yourself? An important reminder. This documentation of advanced care planning only goes into effect if the individual, the patient, can't speak for themselves. Again, this document could be changed at any time, at any point, if new goals of care are determined or new understanding of one's values or personal preferences change. Advanced care planning can develop a framework by which healthcare decisions are made, can define key priorities at the end of life. And it can also shape future clinical care to fit your individual preferences and values. So the first step in advanced care planning, and probably the most important step, is identifying your healthcare power of attorney. This person should ideally be the person that knows the most about your values, what you want most out of life, what you enjoy most from life, and you would feel comfortable speaking on your behalf if you couldn't speak for yourself. This person may be your spouse, a significant other, a long-term partner, an adult child, another close family member, maybe a friend. If you don't have any of those people in mind, it could also be somebody from your community, maybe a work colleague, a coworker that you've worked with for a long time, or a neighbor, somebody that lives in your community, or maybe it's a church friend, somebody that you have gotten to know over the years. Whoever it is, you should have a conversation with them, first asking them, would they be comfortable speaking on your behalf and making key medical decisions? Do they feel like they have the knowledge and the understanding of what your values are to be able to speak up when you can't speak, if and when you can't speak for yourself? The second part of the advanced care planning document is in regards to key medical decisions. One of these key medical decisions is the code status, and you may hear this referenced to as things like DNR, DNI, or do not resuscitate, do not intubate. Okay, so a DNR is an order to not pursue an aggressive medical treatment such as CPR if one's heart or lungs stopped working. Key considerations about this include an understanding about your prognosis of the disease. So it's important to keep in mind, what has your healthcare team or providers discussed with you in regards to your current situation? What type of treatment are you undergoing? Is it something focused on a curative intent? Is it more of a palliative or symptom control, or trying to keep the disease at bay? What is the expected or hopeful outcome? What do you think of when you think of living well? All of those factors will play into whether or not you would want to have an aggressive measure, such as chest compressions or electrical shocks on your heart or on your body if your breathing or your heart were to stop. It's important to keep in mind that a DNR order is separate from other aspects of care. The only thing the DNI order addresses is whether or not CPR or intubation is performed. It does not dictate any other aspects of life-sustaining therapy, such as tube feedings or pain medications or other aspects of your treatment. And again, these decisions can be changed at any time and only go into effect if you cannot speak for yourself. Palliative care is a specialized medical care for people with a serious illness. It's a type of care focused on providing patients with relief from symptoms of pain during their serious illness. The goal is to improve quality of life, both for the patient and for the family. Palliative care is provided by a variety of care team members, such as the patient's primary doctor, or maybe nurses or other specialists who work with the main provider, the main physician or provider, to add an extra layer of support. Palliative care is appropriate really at any age and any stage of a serious illness, and can be provided with curative treatment. The palliative care team can help with ongoing pain management, no matter whether or not you've had any kind of invasive procedures or surgeries or not. They may also help with management of any side effects, such as nausea or dizziness that may occur from treatments like chemotherapy or radiation. The care model of hospice includes palliative care, and the focus is on alleviating discomfort and managing any other symptoms that may arise. The care team is led by a provider who specializes in providing end-of-life care. It usually means no longer performing regular lab or imaging assessments. It means removing any treatment that is not in line with keeping the patient comfortable, or could potentially be a barrier to you, the patient, enjoying time with the people you love the most. Hospice can be provided in a private home, in assisted living, or long-term care facility, really wherever the patient lives. The focus of care becomes more about quality of life at this stage. Many hospitals also have a hospice wing, and so if a care transition can't happen to make it possible for a patient to receive the kind of support they would need at a home environment or a private facility, a hospice wing is a great choice if things are moving rather quickly. There are a lot of resources offered to you and your loved ones as part of hospice care. A multidisciplinary team of social work, of nurses, and palliative care providers can help support and navigate this part of your care. This frequently involves meetings with you and your caregivers and family and other providers to help you understand where your condition is at and what to expect. These opportunities of meetings also give time for sharing feelings, asking questions about the overall course of the dying process, and can help provide families and loved ones care and support. The hospice team really helps to coordinate the care 24/7. In closing, I want to leave you with a quote by Dame Cicely Saunders, founder of the first modern hospice. "You matter because of who you are. You matter to the last moment of your life. And we will do all that we can, not only to help you die peacefully, but also to live until you die." I hope that you found this information applicable, no matter where you are in your processing or receiving care with your sarcoma journey.
I'm Michelle Kolling. I am an end-of-life doula and founder of HELD, which is my doula practice. HELD stands for Holistic End-of-Life Doula. And I took training through ANELDA, which is the International End-of-Life Doula Association. Did a training with them and have been working as a doula as a volunteer and also privately for the last, I would say 2.5, 3 years now. And it's really, really beautiful work. I help people die, is what I like to say. As doulas, we bring a sense of sacred back into the dying experience that has really become a medical experience. We provide practical, emotional, and spiritual support for the person who's dying and their caregivers. We help the families, and the person who's dying really live until their last breath. A lot of times, in my experience, when that terminal diagnosis, that life-limiting diagnosis is given, people feel like their life is over, and it's not over. We like to help give them a sense of power back, and embrace this part of their life, which is just as sacred as birth. Birth and death are really the sacred bookends in life. I can help caregivers get a structure to this new system. When you've been living with a diagnosis for a long time, you have a team of doctors, you have a team of nurses, you get really used to it. You develop a relationship with them. When the time comes for hospice and you elect hospice, that whole thing goes away. You get new doctors, new medications, and it can be really an upheaval. You've gotten used to one thing, and now you kind of have to start over again. And that transition can be really hard. So that's part of what doulas do, is can help ease that transition, help educate, help normalize what they're going through, and then really sit with that person who's dying. Most of us don't get to know when we're dying. It changes your perspective on things when you now know. And how do you want to spend these last days, weeks, maybe months? What's most important to you now? What do you want to protect your energy for now? And really helping them to do that. With that terminal diagnosis, a lot of times people feel like their life is over, and your life isn't over until your last breath. So I really love and feel privileged to be able to help people create that life that they want until that last breath. My experience has mostly been in people's homes and also assisted living or nursing home facilities. We definitely can go into hospitals. Other doulas I know do. We can pretty much go anywhere. Typically when I first meet with someone, I get to know it's a getting to know them process. The process is very similar. The individuals are very different. Family dynamics are different. Sometimes that's part of the process too, is being that objective third party that is really protecting that dying person's interest. So I'll sit with them and ask them, how does it feel now that you know you're dying? What's important to you? We have some tools that we can use, some tricks of the trade to help tease out those things. And then really make sure those things that are important get focused on. Help the family focus on those things. There's often competing, everybody wants to help and everybody has an idea how to help. Making sure that the person who is dying is the interest that everyone is really looking out for. We can help legacy planning. A lot of people, when you say the word legacy, people think, well, I'm not that important. There's not going to be a library named after me or a statue in a park. That isn't what legacy is. Legacy is what's left behind, how people will remember you. A lot of that turns into letter writing or giving special objects away, meaningful things to people while you're living. It can mean a lot of different things. So we talk about maybe the more difficult experiences in their lives, where there may be some regret, and dig into some of those harder experiences that they have a different perspective on now. A lot of time there's when do we start saying goodbye? I can help normalize the body experiences they're having. We can go a little deeper spiritually if that's what they want and that's what they need. Ritual is a big part of what we do as well. Our lives throughout human history, big things are marked by ritual. And there's rituals that we can bring into the dying experience and the after-death experience for the families to help ease that transition. So really for me, also having been a caregiver, my heart is always with them. And I go in and I can feel what they're feeling, which is often overwhelm. So I like to create as much space as I can through finding a circle of very trusted inner circle people that can help with the physical needs, help with the medications, help with the bathing, help with the toileting, and help that caregiver, that spouse or that child or mother spend as much time as they can with their person, just loving them and letting go of some of that caregiver role. That's a really important piece of it for me as well. Hospice is 24/7 by phone. Right. They will, and they can't always be there. So when I say 24/7, they have a number you can reach out to, but that doesn't mean there's going to be somebody physically there. In a facility, it's the same. Because again, it's a medical model, and it's different from your other care team that you had. So even if you're in a hospital, you're going to have the hospice nurses visiting, and the hospice doctor is going to be directing the care. When we get a new client, we will sit down with them, and again, it's very individual, and we will design a plan that works for them. So in the beginning, we might see them a couple times a week, and if they're really stable, which often happens, when people go into hospice, suddenly they feel really good And, you know, there's a bounce there that's pretty common. If they're doing well, maybe we'll meet once a week. As things speed up, we might meet a couple of times a week. In the active dying process, we can be there every day. And again, it's very individual. Some, you know, as doulas, we also have to put boundaries around it. But we like to help with that coverage when we can fill a gap that really needs to be filled. But also empowering the family that they can do this on their own and helping them, giving them a roadmap to do that. I try to reach people when they're well, and that's been my challenge. You know, we live in such a death-phobic culture that people really don't even want to talk about it. They're afraid if they talk about it, they're somehow, you know, bringing death closer, or you know, they're going to summon it, you know. And we kind of laugh. It's sort of, you know, every profession has its humor, and one of the things doulas say, it's like, you don't get pregnant by just talking about it. You're not going to die by just talking about it. So I like to bring, I want to bring some of that normalcy back in to the death experience. And I've also pursued education and training and certification in as a life coach. So I'm also a life doula. And, you know, Frank Ostaseski says, paraphrasing, you know, why wait until the last weeks of your life to do the work of your whole lifetime? And I feel like if people welcome those conversations and live their life through the lens of I am going to die, it really changes the way you live. More realistically, when you receive that life-limiting diagnosis, I think is a great time to reach out to a doula, because your life changes anyway. Your life is, even if you live, which was, you know, wonderful, and a lot of people do, your life has changed forever. So it's, you know, to have some help and support with people who are comfortable in that place is really useful. And again, we're not competition for hospice. Hospice is wonderful, but they're really limited. There's a misconception out there that hospice really takes care of everything at the end of life. The reality is they're there a very short period of time. You might get a nurse maybe twice a week for 30 to 45 minutes, depending on how fast the process is happening. You get, you know, massage therapists, music therapists, and spiritual guidance as well. But it's really limited, and they, you know, train you in the new medications, and they're 24/7 by phone. But they're not, the family really bears the burden. And that is something that's people aren't aware of. Often, you know, it will be a son or a daughter that will engage the doula. Again, it's, for me and for most doulas, it's centered around the person who's dying, but oftentimes we are engaged by a family member. And there doesn't have to be a catastrophic disease process. Most people do die in their old age. And just kind of start slipping away, and we can have those conversations and ease that process. There's quite a few national organizations. In Minnesota here, we have this wonderful organization called the Minnesota Death Collaborative, which is, when I decided I wanted to do this work, I found them, and I'm now proudly part of the steering committee for for this wonderful community of death workers. We have members from all different disciplines, and there's a member directory there. ANELDA, who I trained with, is a national organization, and members are able to list there, as well as NEDA, which is another national organization. It's getting to be a more well-known thing. It's very much based on, in fact, the training was designed after birth doula training, which was kind of a new thing in the 70s and has now really been accepted and is very much in the mainstream. So that's kind of where we're at now, where people are starting to get the word out and knowing more about us. You should be able to find somebody with a Google search, for sure. Grief and processing grief is a big part of what doulas help families with too. We talk about anticipatory grief, which not everyone understands. They know they're feeling something, but anticipatory grief is really that grief you're feeling before the death. And that comes in even with a life-limiting diagnosis, even before you know you're reaching the end of your life. Your life as you knew it is over. There's a grieving process with that. Identities change. There's a grieving process with that. And normalizing that for families. The 5 stages of grief are talked about a lot. It's not a linear process, and not everybody experiences all of the stages of grief. I know anger is one of them. I never had any anger. I never did. Some other people, who experienced the same loss I did, were angry. And, that's part of the challenge too, is grieving is very individual, just like we are. Some people really thrive in a support group setting, and that's really good. Some people don't want that. Some people want therapy. It's really, for me as a doula, it's helping people reprocess in those early stages, normalizing what they're feeling, giving some tools to help them through it, keeping people connected to their body. Grief is such a physical experience, and I think that those physical symptoms were a surprise for me, and they're a surprise for a lot of people. So again, normalizing what that is, giving people permission, letting grief do what it needs to do. It will end. It doesn't feel like it will, but you do need to experience it to reach that end. The love never ends. I remember a time in my grief process too where I thought if I didn't grieve him actively and if I didn't cry anymore, that means I didn't love him enough or I didn't love him anymore. And that healing process really allows for that love to expand, and it really can be a beautiful, life-changing, in a positive way, experience. But you do have to experience it.